So today's objective is to discuss about basic things about transplant, what happens in transplant, the bone marrow transplant, and what is the role of caregivers in the bone marrow transplantation unit. How is it unique or separate or different from what we do it in regular oncology wards? We have one or two case scenarios to discuss, and later followed by questions. So that's how it is. That's a typical example for a bone. Inside the bone marrow, there is a spongy component. This is the spongy component, soft component, where there are stem cells. These are the stem cells. So these stem cells, they have a capacity to multiply. They will continuously be multiplying, and also they produce three different type of cells. Red cells, also called hemoglobin. Second one, the white cells, WBCs. The yellow cells, or sometimes it's also called platelets. So each of these cells, they have a different function. This entire group of white cells, there are five or six different type of cells. These cells, they help in providing the immunity to human body. Each individual, for example, neutrophils will fight against bacterial infections. Lymphocytes will fight against fungal and viral infections. So there are each of these, they have a particular function. They help in identifying any infection in the human body, and they take care of it. The red cells, they give energy to the human body by supplying the oxygen to the whole body. So without red cells, we can't survive. So it's very, very important to have red cells in sufficient numbers to provide oxygen supply to the whole body. The third one, also called platelets, when they aggregate, they help in prevention of bleeding. It mainly helps in clotting of the blood whenever there is trauma, any injury to the human body. So all three are very, very important, and without this, human body can't function. They can't be alive. But in transplant process, what happens is that, so all these three are produced inside the bone marrow, and bone marrow is the one which maintains all these three cell lines in the blood in a sufficient amount, or in sufficient quantity, in sufficient number. So any issue with production of these cells, or any abnormal production of these cells, will lead to some issues, which may be one of the indications for doing a transplant. So then we're coming to the thing, what is transplant? Transplant is called by various names. It's also called stem cell transplant, also called bone marrow transplant, also called hematopoietic stem cell transplant. So basically it's a complex process where patients whose stem cells are already, either they are diseased or their bone marrow is destroyed, they are not able to function normally, their marrow cells are replaced with the normal healthy stem cells from a healthy donor. That is the process of transplant. But it doesn't look like, it is not that simple as what we say, just to replace with this and this. It's not like giving blood transfusion and transplant, okay. No, it's not like that. It has multiple process involved in it, which I will take you through the coming slides. What is BMT? It's a complex process. Of course, it will require selection of patients, starting from whether they are fit or not, including various things we'll discuss in coming slides. But what is important is that one, bone marrow transplantation is one only curative option for many cases. For example, a child with leukemia, if it relapses, the only curative option is transplant. Without transplant, the child can't be surviving later. Of course, we use chemotherapy, immunotherapy, radiation, surgery, and various other modalities of treatment to controlling the tumors. But some refractory cancers, some cancers we have not responded to the conventional modality of treatment, there again we need bone marrow transplant. Of course, bone marrow transplantation is curative in many other non-oncological cancers. So then where are we doing the bone marrow transplant? What are the reasons? So as I told you, bone marrow, its function is to produce three different type of cells. Bone marrow, there are some conditions called bone marrow failure. What is bone marrow failure? The bone marrow will stop producing one or more different type of cells. So many of these, sometimes it could be age dependent, sometimes it could be due to various other secondary causes like infections, some chemotherapy, some exposure to chemicals, carcinogens, radiation, whatever may be the exposure, whatever may be the reason. When the bone marrow stop producing the stem cells, the only curative option is transplant. Similarly, sometimes the bone marrow produces defective cells. For example, a condition called thalassemia, where the bone marrow will not be able to produce only red cells. White cells and platelets are normally being produced. But when the red cells are not normally being produced, the patient will have anemia. That anemia lead to other changes. So their lifespan will come down. So to correct that, the only curative option currently available is transplant. So similarly, the bone marrow is defective in various other situations, for example, sickle cell anemia. So these are the various types of conditions. There are some conditions where bone marrow is normal, their production is okay, but they have been infiltrated by other cells from the various parts of the body, or other type of infections or something, which will lead to defective production of the cells. For example, there is a condition called storage disorders. If anybody is working in the pediatric wards, they will be knowing it. So storage disorders where children will not be able to metabolize what we eat. For example, the glycogen or the carbohydrates we eat. Some kids will not be able to digest or metabolize it properly. So what they do is they will go and store inside the bone marrow, and that will lead to bone marrow failure because it is infiltrated with outside cells. Similarly, leukemia. Leukemia is a blood cancer. What will happen is the normal cells, whatever stem cells is there in the bone marrow, it is being replaced with some abnormal cells, which are cancerous cells. So because of this infiltration, the bone marrow will not be able to produce normal cells. Again, that's another indication. There are some kids which are born without proper immunity. You must be knowing we all have immunity cells in our body. There are some kids who are born without appropriate immunity producing cells and appropriate immunity producing proteins in the blood. So these are called inborn error of immunity. These kids will require transplant again. And of course, as we discussed, there are some refractory cancers. So these are the various types. I'm just giving you the explanation. What are the various situations we may require? So if you come to the indications or particular conditions where we require transplant, there are two types of indications. One is cancers, leukemias, lymphomas, multiple myeloma, myelodysplastic syndrome. These are the various common indications which we do transplant in cancers. Of course, in children, we do it for neuroblastoma and other conditions. So for non-cancers, as I already told you, aplastic anemia means the bone marrow is failed. It's not producing the cells normally. So this is a bone marrow failure. Hemoglobinopathy, for example, is thalassemia. As I already discussed, thalassemia, it's a defective production of cells. Again, I told you immunodeficiency disorders. There are some congenital blood disorders like PNH also where we require transplant. So basically, these are the common indications where we do the transplant. So what are the types of bone marrow transplant? So basically, there are two types of transplants commonly. One is autologous, where we use stem cells of the same donor for the transplant process. The other type is allogenic, where we use stem cells from a healthy different donor. So what kind of donor, that we will discuss in the future. How we say that we are doing stem cells from the same donor? As I already told, the bone marrow is defective. No. There are some conditions, for example, refractory leukemias, lymphomas, where we have to use high dose chemotherapy, which is not possible to deliver that kind of treatment in a healthy normal individual. So what we will do then, what we do is we collect the stem cells from this bone, where in this patient in autologous transplant, wherever we are doing, the bone marrow may be normal, but to use or facilitate the high dose chemotherapy, we use sometimes autologous stem cell transplant. The common, for example, is multiple myeloma, neuroblastoma. These are the conditions we use autologous stem cell transplant. In allogenic, we use the stem cells from a different donor. So depending on the type of donors, there are various types of transplants. For example, if you use stem cells from the same donor, it's called autologous stem cell transplant. Allogenic is a basket. There are various types of stem cells you can use it for allogenic stem cell. For example, if there is a twin and there is a match stem cells from the twin sibling, then it's called match sibling or syngenic donor. There are sometimes brothers or sisters which have similar matched bone marrow that I will discuss in the next slide. So if it's a matched sibling is available or a parent is available, it's called matched related transplant or matched related donor transplant, MRD transplant. Sometimes there are unrelated donors available. Matlab, the patient and the donor is not genetically or not biologically related, but they may have a similar genotype or genetic type which will help us in selection of the donor. The typing is called HLA typing. I will discuss, of course, in the next slide. But sometimes unrelated donor also will be used for doing the transplant. So this is one of the famous pictures. Salman Khan, he donated stem cells to this baby Pooja, child with thalassemia, and he had a full match with Salman Khan. So it was in the news in 2010 where he donated the stem cells and the child is doing okay. So it happened at Tata Memorial Hospital where I am trained. So this is my teacher, Dr. Naveen. So how do we choose the donor? Of course, it depends on various factors. Most important thing is HLA typing. So just like when we are giving blood donation or blood transfusion, we usually check for blood grouping. Similarly, while doing transplant, we need a genetic level of match. So genetic level of compatibility is very much important before selecting a donor for transplant. If the HLA matching is not there, then it is considered a haploidentical transplant where the chances of success of transplant will be less and the chance of complications and other issues will be more. So we always try to find HLA identical donor to get a matched donor, matched HLA matched transplant. So that is most important factor. Apart from it, blood grouping, general condition of the donor, other comorbidities of the donor. For example, a donor with 65 years of age with diabetes and hypertension, we may not be choosing him as a donor because of comorbidities. So because he may not be stable enough to donate the stem cells. So all these things are there, the age of the patient, so and the donor as well. So these are the various criteria or the factors which we consider before selecting a donor. So these are the various steps of transplant. I will go through one by one. The first step is collection. The collection of stem cells from the donor happens two ways. This is the older way where we inject the needle directly. The patient is in a prone position, directly inject the bone into the vertebra or the iliac bones, hip bones. Inject the needle there, collect the stem cells from there, preserve it, store it, and later use it for transplant. This is one of the older way of collecting of the stem cells. This is the current way of treatment. This is also called peripheral blood apheresis, where there is a machine. The patient's blood will go to the machine, it will filter out, and only the stem cells which are necessary, those will be collected and kept in the bag, and the remaining things will get back to the patient. So only the required or necessary cellular part of the blood will be collected from the patient. and rest from the donor, and rest will be given it back to the donor. So I was telling that the stem cells are there only in the bone marrow. Then how are we collecting it from blood? So what we currently do is there are some medications available. So this process is very cumbersome. It has a risk of infections. The patient has to be anesthetized for a longer time. The chances of failure of adequate collection will be there. So this is one of the very cumbersome process, and this has been replaced with a newer procedure where currently there are some medications available where we will inject that patient donor prior to collection. That patient will be receiving for 5 to 7 days. They will receive continuously some injections, medications, which will help the stem cells from the bone marrow to come to the blood. So during that process, we know that when it comes, so there are some timeline and other things to be calculated, and we give that medication, and on that particular day, when the stem cell yield is very good in the blood, we collect it. So the first step is collection. That's very important. So we need to collect stem cells. Either if it's a patient itself, we will collect it from himself, or it's from the donor, we have to collect it. And that collected stem cells will be processed and it will be preserved. The second step is conditioning. Conditioning is when we want to replace stem cells from a healthy donor, the existing marrow has to be destroyed, has to be killed. Because if the existing cells are already there, then they will not accept the stem cells of the donor. So what we have to do? We have to use various agents, regimens to destroy or to clear the already available or defective bone marrow. How do we do? We do something called chemotherapy. There are chemotherapy which are called myeloablative chemotherapy. It's not a regular dose chemotherapy. These medications are not used in regular wards. This will be used only in transplant wards, where we will use high dose chemotherapy to destroy the entire marrow. Sometimes radiation or combination of both. All the three may be sometimes used. This we have already know. Regular chemotherapy, patient will be having a central line like this. The chemotherapy will be through a infusion line. They will receive the chemotherapy. It's a usual way. Everybody must have seen the patients receiving chemotherapy. This is the radiotherapy machine. The patient will be counseled and made him lie down in the radiation unit, and the machine will move and the whole body will receive radiation. That's called total body radiation. It's also one of the modality of destroying the bone marrow of the recipient patients. So commonly used in leukemias, especially for children. This is one of the most important modality. We use it in transplant. So the third step. So we have prepared the bone marrow, which is called conditioning. So the marrow is been cleared now. So now there is enough space for the recipient stem cells to come and sit. Now we are already collected, the stem cells are already preserved. Now we are infusing the stem cells through the central line again.
So in this side, so the radiation therapy is given to destroy the
bone marrow. Correct.
Bone marrow, right?
Correct.
After this, is there a way to figure out the bone marrow has really been destroyed, or do you do some tests, or it's just a...
No, we need not always taste coffee that whether we put sugar or not. We do not taste. We know that 1 spoon of coffee will make it. So how we know that? There are various studies, of course.
Okay.
So there are some dosage of radiation which is necessary to destroy the bone marrow. Normally what we do is that the dose is 2 to 4 grays. If you give 4 gray of radiation to the bone marrow, it will be destroyed. We have multiple scientific studies done in multiple conditions. Also, patients or the random people who have received radiation during nuclear reactor blast like Chernobyl, or like patients received radiation during Hiroshima, Nagasaki. Those who had exposure of up to 4 grays, they finally ended up having either leukemia or marrow failure. So we know historically that radiation will cause bone marrow aplasia. But of course, your question is very valid, because what if it's not clear and you infuse? So normally what we do is we use supra-therapeutic levels of that radiation. We usually go up to 12 grays. So it's almost 3 times what is needed to clear the bone marrow. Along with it, we also give chemotherapy. So by single modality of treatment, radiation is not used. We usually use a combination of chemotherapy plus radiotherapy.
Okay. Now my question is for the next slide. So after radiation and before doing this process, right, there is a gap.
Correct.
Right? You're not doing it immediately.
Correct.
So what in that period, if there is a complication for the patient, or if some of the bone marrow issues rise up?
So bone marrow transplant, it's a no going back procedure. It's like entering the flight. You can't come out of it. Patient's marrow is ablated. If you don't give stem cells, patient will die. Patient will not be able to survive, because human beings, they can't be alive without white cells for more than 20-25 days. So I will explain it to you in future what happens if in spite of doing all the precautions, if the stem cells, injected stem cells, if it's not successful to go and sit in the bone marrow and start producing white cells.
No. My question is not that. Between these two procedures, there is a time gap.
Whatever may be this thing, we will try to treat that indication or the condition, and we'll go ahead with the stem cell process, transfusion process. Yes. We have to, because there is no going back. So what I was telling is, there are some times when, in spite of doing all the precautions, sometimes in 2 to 5% of the patients in haploidentical, when there is no match, body will reject the stem cells. So in that situation, there will be no white cells in the patients for some time.
Yes,
so that timeline is usually 4 to 6 weeks. and we lose almost one third of the patients just because their white cells are not there in the blood, because our body will
Yeah.
not be because you must be knowing that we are surrounded by microbes.
Yes.
We
Yes.
are everywhere. Wherever you touch a table, water, food, air, everywhere there are microbes. You must be
Yeah.
knowing that there are hundreds of bacteria and viruses
Yes.
roaming in this air. So I will come to it.
Okay.
All those things will be discussed. Okay. So just like how the stem cells from the bone marrow it came to the blood, when we inject the stem cells to the patient from the blood, it will go back to the bone marrow. So there are various scientific technologies, techniques and terminologies involved. I don't want to go into the technicalities of it, but we will inject it into the again central line or as a chemoport. From then it will go to the bone marrow and it will start producing the white cells or white cells, hemoglobin and platelets, all the things. But this process from the day of injection of the stem cells till the counts are recovered, that is called engraftment. So that engraftment, till then the patient has to be kept in a sterile, protected environment. So that's what makes BMT a different for caregivers, different process entire. It requires a very unique, different kind of challenges in the transplant unit. So as I told you, first there will be from the donor, we will collect the stem cells that will be processed and preserved. Then for the patient or the recipient will receive chemotherapy or radiation or both. Then the processed stem cells will be infused to the patient. And from then, the engraftment usually will take 2 to 4 weeks, depending on the type of indications, for the white cells and counts to start producing. This is one step in transplant. So, to manage this engraftment process where patient's white cells are zero, patient will require red cells, because red cells and platelets can be easily donated from outside, but not the white cells. So, white cells are important for immunity. So, any one microbe which is there in the air or in the water or in the food or transferred by healthcare providers like doctors and nurses, it can be life threatening for the patient. So we need to be very, very careful. So that's the reason in transplant wards, it is a stereotype example of a bone marrow transplant ward where it's very different from the general ward. What are you noticing it? How is it different from a general ward? Yes, no people, no window, no colorful flowers, nothing, no chappal, nothing. You can see that. So in transplant wards is one place where even the air is so filtered, because all these wards are called HEPA filtered wards, where the air will be purified around 20 to 30 times in a minute. So for example, this room, if it's a this has a 800 liters of air in this room, then that has to be replaced 20 to 30 times in a minute. So there are some various HEPA filters. Next, you can see that there are HEPA filter vents. Yeah, these are the some HEPA filter vents. Next, yeah. So this is a typical bone marrow transplant room where there are patients who will be here. There will be some storage area and attendant's cot. And everything which is the opposite wall will be having a television for just for entertainment, and everything for example requirement including the IV set, oxygen, suctioning, monitoring. So bone marrow transplant is like an ICU. It's there everywhere. Even the patient goes sick in the transplant ward, we can't shift him to the ICU, because if he go to ICU, he will die. If he stays in the BMT ward, because of the environment, he will survive. So most of the patients, when they require transplant, ventilation or any other dialysis, we will try to do it inside the unit itself. These are the HEPA filter units. You can see there are two vents. So there will be one more vent in the down, I think in the opposite wall, where one acts as a pressure, and that will be inlet, and other will be one more will be the outlet. So it will be done under pressure. It will be maintained so that the pressure inside the rooms are higher. These are all called positive pressure rooms, where the pressure inside a room will be higher compared to the corridors. So even if you open the door, the air from the room should come out, not the other way around. So because we are nurses and doctors, we are walking or roaming in the corridors, even from our sweat or our breath, some bacteria may be there that should not enter the BMT wards. So that room is designed that even the entire ward will be positive pressure. So nothing should go enter. So the air will be cleaned. The patients will receive food cooked in a cooker, pressure cooker, whatever it is. It will be pressure cooked. It will be cooked one more time in the pressure cooker and later sent to the transplant process. Water will be always sterile. No tap water. It will always be either mineral water or a hot boiled cooled water. No flowers. No unnecessary items outside. So this is how we maintain the sterility, and we will be successful in most of the times. This is the time taken to complete recovery of the blood cells is called engraftment, where during this engraftment period, the patient will be kept in this isolated HEPA filter wards. These are called bone marrow transplant wards, where the chance of infection will be much less. So during this process, during this period of engraftment, the chance of infection will be there. Because of the chemotherapy and radiation we have given, the patient will be having oral ulcers or diarrhea. The patient will not be able to eat, so we may have to give nutrition supplement supplements. For example, it may be through the line or through the nasogastric tube. Sometimes entire food will be given through the line, which is called total parenteral nutrition. We may have to do various medications to control or prevent the infections. For example, all these bone marrow transplant patients, they will be receiving prophylaxis. Prophylaxis is prevention of infections. For example, fungal infections are very common in transplant patients. We give antifungal prophylaxis. Like they will be already receiving antifungal medications to prevent the infection to happen. So similarly, there will be some bacterial prophylaxis as well, viral prophylaxis. All those things will be receiving. They will be, of course, receiving blood products as per requirement. There is special requirement for blood products. For example, we collect blood cells and we will be storing and giving, right? There will be some live cells, white cells in that blood also. It should not happen that the blood product received from some random donor, those cells will go and sit in the transplant and in the bone marrow and start producing their cells. So there is something called transfusion associated graft versus host disease. So we don't want to cause any harm to the patient by giving blood products from the random donors. So we usually pre-check and pre-select the donors also for the blood donation for these patients. And all the blood products for the patients undergoing transplant, their blood products will be given radiation. So that any live cells there, any white cells which are alive or any infections there, they should be destroyed. So that's extra special care. Of course, there will be an isolation ward. Sometimes we need to give pain control. So all these things has to be taken care in sufficient, adequate levels to make them engraft faster. Of course, in spite of doing all these things, we end up with having some complications. For example, some organ damage. Some patients after giving radiation, their kidneys may get affected. They may go into renal failure. We may have to do dialysis temporarily for some patients. Sometimes electrolyte abnormalities. There may be fluctuation in sodium, potassium and various other levels in the blood. Infections are very common. And all these infections will require higher antibiotics or a next generation because they already are receiving antimicrobials for prevention of infection. So over and above, when they develop breakthrough infections, we may have to give different kind of medications which are selected in transplant wards. So all these things are the complications before engraftment. And around 5 to 10% of the patients we lose in the transplant unit because of these complications. And later comes the graft versus host disease. So a patient who has undergone transplant, especially from a other person, so whatever the genetic level of match we have done, in spite of that, the cells will be of the white cells and the red cells and the platelets will be of a different individual. For example, donor X has given it to patient Y. The donor X's blood will be running through recipient Y's body throughout the life. So there will be some interaction and the cells will not understand whether they are from X or Y. They will only see there are something called molecular crosstalks which happen between the cells, and once they identify that they are not from the same individual, they will fight. So that is immune mediated fight that will cause some organ damage. Of course, when we are doing conditioning regimen for the patient, we use some medications to prevent that. Of course, that's called GVHD prophylaxis. We give some medications to prevent that. In spite of that, around 30% of the patients will end up having graft versus host disease, where the donated stem cells, which once they produce the immunity cells, they will go and act and destroy or to try to damage the organs. These are the common organs involved. So basically, there are two types of GVHD. Acute GVHDs, which happens immediately after transplant up to 100 days. Chronic GVHDs, which happens after 100 days. So usually intestines and liver, these are the common organs involved in the acute GVHD. So patients will usually have diarrhea, loss of appetite and jaundice. These are the common symptoms of GVHD in acute situation, immediately post transplant. Delayed after 3 months or after 6 months, skin. So there may be pigmentation, sometimes thickening of the skin, depigmentation, so discoloration of the skin, sometimes lung changes. It mimics a condition similar to asthma. They can have recurrent cough, decrease in the oxygenation, requiring medications, other things. Sometimes stiffening of the joints, sometimes blurred vision. All these things, this can happen in the chronic GVHD. So basically, these are the various organs which are involved post-transplant. After once the counts have recovered, these are the other issues which we commonly face. To prevent or to control the graft versus host disease, again, we have to give some medications which suppresses the immunity. That will again lead to infections. It's a vicious cycle. If GVHD happens, we have to suppress the immunity, then infections. When we treat infections, we have to reduce the immunosuppression, again GVHD flares up. So it's a vicious cycle. So that is the balance. This is the most important part in transplant. In fact, the first process which I told, that is the very easiest part of the transplant. The engraftment period and the GVHD management. This is what defines, or this is what makes the transplant successful or failure. Of course, in transplant, success or failure will depend on many things, as I told you. One is engraftment failure. So sometimes when we give stem cells, because sometimes it's a genetically different individual, sometimes they reject the stem cells. So when they reject it, we have no other go. We have to choose one more donor, take out the stem cells and we have to transplant. Otherwise, this patient is going to die. No person can be alive when the stem cells are rejected. So it's not possible without a second transplant. Individuals, we can't make them survive. So it's very important. That's one of the engraftment failure. It can happen up to 2 to 5% patients in haploidentical transplant when there is no match. And in such patients, if we don't do the transplant, we are going to lose all of them. Second one is, in spite of doing all this, whatever may be the primary indication, for example, we are doing transplant for a leukemia can still come back. That recurrence will be there. So in spite of doing transplant, the leukemia recurrence risk is there. So that depends on the type of leukemia. For example, new patient with, for example, acute leukemia, he has undergone transplant because it's a high risk leukemia. The chance of recurrence is, for example, is 20%. If it's same thing in a relapsed leukemia, the chances will be 40-50%. So the recurrence risk will increase on the type of leukemia and whether it's relapsed or not also. And of course, over and all of this, I told you, when we are managing graft versus host disease, we need to give immunosuppression medications, which will cause immunity to fall. So the opportunistic infections will again happen, and that will lead to death. So either because of the GVHD or due to infections, again we lose some patients to death. So in autologous stem cell transplant, where we are using person's own stem cells, then the chance of engraftment failure will not be there because it's his own stem cells, so they usually accept. The GVHD chances will be not there. So the success rate will be much higher in autologous transplant because these two risk factors are not there. The disease recurrence can still happen in autologous transplant. For example, multiple myeloma. Usually half of them will have a multiple myeloma coming back in 3 to 5 years. But in spite of that, the patient will survive for 5 years without any issues. Then we can do one more transplant after 5 years. Again, we can give him life for another 5 to 7 years. So it's like that. So the disease recurrence can still happen in autologous transplant, but these two factors will not be applicable for autologous transplant. But in patients who are allogenic, they're receiving stem cell from the other person, the risk of GVHD and the engraftment failure will be there always, along with disease recurrence. So in a realistic way, if it's in a matched sibling donor, the best cure rate we achieved is around 70 to 80%. So 20% of the patients we may lose for these factors. If there is no match, the cure rates will fall further. It may be close to 50%. So means 50% or half of the haploidentical patients, probably 40% of them, we may lose in long term because of these various factors. So I hope I'm clear, or I've given some gist of the transplant process. Any questions, please? Anybody? Yes, please.
From the perspective of the donor, right, with the same person doing it to himself, yeah, most of the questions are answered. But the other person donating, right, from his perspective, what are all the things that he should consider? Because if I'm the donor, I'm donating it to somebody. So how careful or what all tick marks should I be doing?
First of all, it's a very, very safe procedure, and the amount of stem cells we are taking to keep the donor alive is very small amount. Human body, as I told you, the stem cells, they continuously replenish themselves.
Yeah.
So even if you take 1% of them, it will replenish in no time. So for a donor, it will not be any issue, except that I was showing some pictures for donation. I told you previously we were doing inserting bone marrow.
Yeah.
So that is a very painful and cumbersome procedure. So that has been replaced with now more simpler, effective procedures. But in spite of that, they have to take 2-3 central lines, sometimes in the elbow or in the neck. They have to take a central line for a collection of sample.
Yeah.
So that is one painful procedure. Second, they have to receive that growth factors for duration of 5 to 7 days. That will lead to body pain, fever, malaise. It's like a viral infection. So these things will be, but most of these are very short-lived, nothing significant.
Okay, sure. Thank you.
Doctor, we have heard that radiation, exposure to radiation causes cancer.
Correct.
So now you say the person who is having some bone marrow issues, you'll be putting him to radiation so that the bone marrow will be taken care of. But is he not put at a risk of another cancer?
Completely agree. There are some long-term complications of transplant. That includes development of second cancers because of the chemotherapy they have received, because of the radiation they have received. But that usually happens after 5 to 7 years. So what we are currently focusing, today's topic is mainly introduction. So that's why I didn't go into the details of it. But definitely the chances of second cancers, it's as high as 2 to 3% of patients who undergo radiation and chemotherapy both. And it's lower if only chemotherapy is used. But that usually, complications will usually happen after 5 to 10 years, 15 years later. So we are not much concerned because at this point of time, if I don't cure the leukemia, the patient will not be surviving anyhow. So we accept some long-term toxicity risks of the radiation and chemotherapy, and we go ahead with the transplant process. Of course, science is being evolving, and many newer things have been getting trained. Of course, you must have heard about something called CAR T cell therapies. So it's a newer kit in the market. So it is a kind of training your body's own immunity cells to go and kill the cancer cells. Of course, a lot of genetic engineering is involved in it. So currently it's in the research phase in India. It's already available in US market for almost 10 years. But we're trying that. So we are trying to use more safer options to either avoid transplant altogether or use other gentle medications to use it for conditioning of the transplant. So we are using that, but it will take some time.
Yeah, my second thing is I work at Rashtrotan as a volunteer, Yoga Kendra, and they have this thalassemia patients regularly as for blood donation. So now that you said this can be cured, like BMT can help. So is there any, because there what I have seen is more people from a lesser privileged come there. So is there any, as a part of Shankara, I just want to know, as a volunteer, can I suggest that these things are available for them?
I'll tell you. This is much more complex, but I'll tell you why.
Okay.
Please.
Okay.
So at Shankara, it's a cancer hospital, and currently we're only focusing on oncological perspective, oncological indications. If I see initially when I showed the two indications, different indications, the cancer part, because Shankara can help to raise funds and help only for cancer patients. I can't raise funds for non-cancerous patients. First thing. Second thing, non-cancerous patients like thalassemias, it is more challenging to do because most of them they will not be having match. As I told you, if you do 10 transplants, currently if you are doing 10 transplants, only 2 will be having match. Rest 7 to 8 will not be having a available match. So our 70% of the workload is haploidentical transplant, where the cost of the treatment is much higher compared to the match sibling donor. So when such a things are involved, these patients are already poor. They really don't afford. And there is no center in the country which are doing transplant for such non-cancerous indications at a concessional rate. Because the cost of the treatment is so expensive, it's really, that is the one thing which is forbidding many patients to get into the transplant process. And I would, of course, everybody would agree, and the senior doctors will definitely agree, the cost of the treatment in India for any particular disease is very less compared to a counterpart in US or in Europe. For example, I told you, the CAR T-cell therapy, it easily costs around 5 crores in US. So in India, where I was a part of it, and Tata Hospital, where research was ongoing, they are trying to bring down the cost or to provide it to the community at a cost of close to 20 to 30 lakhs. So such is the difference. It's almost 90% reduced cost because it's manufactured within India. So when such things are involved, the transplant process, and one more thing, important thing is, the thalassemia child is happily roaming around with blood transfusion. And the chances of, as I told you, around 20% of the patients we may lose during the transplant process. Family will not accept if anything happens during the transplant. Because the child, they will say, बच्चा तो खेल रहा था, आपने बोला कि transplant करने के लिए बोला, हमने 25 lakhs भी दिया और अभी बच्चा मर गया. So that acceptance, for cancer, it's no other go. Cancer, there is no alternative option available. For a benign condition where there is non-cancerous condition, they're happy with that condition. They're receiving transfusion once in 20 days. Of course, their effective lifespan will come down from 60, 70 for an average adult in India to 30 years. But they will accept that than this. So it's very, very challenging to, so especially at Shankara, we are not focusing on non-cancerous, but there are many other social and financial aspects involved in choosing why we are not doing benign hematological transplants. It is curative for thalassemia. Yes. It's a curative for them. Actually, if you go to US, no child will receive transfusion like India. It's only for third world countries. All kids in Europe, in Northern America, when they are diagnosed with thalassemia, by the age of 1.5 years, they will undergo transplant. Every child. Of course, they are focusing on reducing the incidence of thalassemia by premarital counseling and screening and identifying it. It's very simple. A simple blood test will identify whether you can have a child with thalassemia or not. It's a very simple test. So, of course, many NGOs are working on that as well.
Sir.
Yes.
Sir, how long it will take for the completion of this entire process of transplant? And the patient is out of danger, we can see.
I'll tell you. The normal transplant process in an autologous situation will usually take around 8 weeks. So that's roughly around 2 months. Autologous is when its own stem cells are used. In allogenic, whenever there is a match sibling donor, roughly around 4 to 6 months. In haploidentical transplant, one patient I have treated for 1.5 years. He had some infection, and because of the infection, the treatment was going on for 1.5 years. So it can vary between, but average length is autologous 2 months, 4 months for match sibling donor, and around 6 to 9 months for haploidentical transplant.
Out of risk after that period. No immediate risk.
Yes.
Okay. Thank you, sir.
Actually, I have a question. Now we are getting small kids with blood cancers.
Yes.
For 3 years, 4 years. And my own maid, her son was diagnosed with blood cancer around 4-5 years. What could be the reason for it? Like, is it
I understood your question. I'll tell you. Please sit. So, cancer, it's generally considered one of the disease of older age. For example, if you come to Shankara, 80% of the patients are above 40-50. So, the incidence of cancer in younger population is very less. Basically, it's because of the aging. You will acquire some genetic changes in the body and you will develop some cancer. Second thing will be lifestyle. What do you mean by lifestyle? Smoking. drinking, consuming alcohol, chewing tobacco, obesity, consuming some non-vegetarian food. Many of these factors are contributed or contributing factors or risk factors for cancer. You will acquire over age, but for below 30, 40 years, the risk factors are very minimal or you can't define it. That means out of 100 children or 100 younger, below 40 years, if you see cancer, only 2 or 3 will have some reason for cancer. Rest 97 or 98 will not have any reason. It's idiopathic. Without any reason, it just happens. It can happen to anybody. It can happen to any individual. Even animals also, they develop cancer. You must be aware of it. So it's like that, yes. So it can happen to anyone. There is no reason. I have treated a child who at a day 2 of age. Just next day of the birth, we started treating. So, and the cancer diagnosis what happened when the child was in utero, inside the mother's womb only, it was diagnosed. So, it can happen to anybody. But of course, those things are rare. So, for example, to a Bangalore population of 1.5 crores, I'm just estimating it, roughly we estimate that around 400 to 500 kids will be developing cancer a year, compared to 40 to 50,000 adult patients. It's much, much higher in adults compared to children. So we don't have any reason for it. As I told you, the 2%, there is something called familial inheritance for cancer. There are some genes which are transferred through the genes which can lead to cancer. For example, in children, there is a cancer called retinoblastoma, eye cancer, that transmits through a gene called RB gene. So that is autosomally dominant transmission. So if the parent have it, their kids will have it. In women, when they have, especially when any women develop breast cancer below 40, 45, we usually counsel for testing, genetic testing for BRCA mutation, BRCA1, BRCA2, and TP53. These are the ones which can be inherited and that can lead to cancer at a younger age. Because normally, adult women of age 35, 40 or below that should not develop breast cancer. If they are developing it, there may be a chance that it could be genetically inherited. So we usually test for it. And our success rate is much higher in those patients to pick genetic cause. But in 98% of the people below 35, 40, we don't identify any particular reason.
This recurrence of some cancers, for example, metformin, prolonged usage of metformin is found that their children can also have cancers. That's what one study which I read a recent thing. Can doctor tell?
I'll tell you. If you read Google, there will be hundreds and thousands of things which they say that it can lead to cancer. Unless they are scientifically tested, at least doctors will not recommend that you should avoid metformin. Because metformin is usually used in diabetes, and when you are producing kids, you will not be using metformin, usually. So it's very, very unlikely to cause cancer. But there are particular reasons, specifically, as I told you, in radiation. For example, after Hiroshima and Nagasaki, many people developed blood cancer, thyroid cancer, and other cancers. So radiation is one of the important factors. So if you, for example, many people who are working at Kaiga, I have one relative who was working at Kaiga, so they won't allow him to work beyond particular time. So they work for 2-3 years and they'll give a gap of 2 years because their body will be continuously being exposed to radiation. Of course, it will be counted and measured how much they're exposing. But these are one of the risk factors. Second one, benzene products. All this engine oil and the people who work with those things, because many of these hydrocarbons, they get through the skin, it may be possible that they may lead to blood cancers, bone marrow failure and other things. So these are some of the things which are known carcinogens. But I'm telling you, if you are avoiding smoking and alcohol and chewing tobacco, if you're not consuming too spicy food, virtually avoided 90% of all carcinogens. So that's what I can say. Yes, definitely agree. When you overcook, definitely, especially when you are directly cooking on a grill. So that super cooked food, sometimes overcooked, it can lead to some carcinogens. Again, there are very few people who do regularly eat those kind of food. But if you see, the tribals, they regularly eat charred cooked food. They are very healthy. So it may be. So we don't know actually. At this point of time, we don't know. I told you, ma'am, in autologous transplants, the cure rates, of course, it depends on the indication. For example, multiple myeloma, if you only talks about survival, it can be as high as 80% or 70%. So usually what I will say is that if you do match sibling donor transplant, the cure rates are somewhere close to 70%. If there is no match, it is somewhere close to 50%. It's very generalized. There are some conditions, for example, aplastic anemia, when the bone marrow is failed, the cure rates are higher. So it depends on the case-to-case basis, it varies. But in general, haploidentical transplant cure rates are only 50% or 50 to 60%. If there is a match sibling donor, the cure rates are 70%. And if it's autologous, it's 80% and above. That's what I would say. We can do that. So what I'll do is I'll quickly brush through it. I will not take, so all these are done. Yeah. So what are the salient features of caregivers for transplant? As I told you, the transplant process is really lengthy, and part-time caregivers will not be applicable for transplant. This is the first major thing. So that's why we usually prefer a close family member, and unless they have a designated person who is willing to be a caregiver, we will not transplant a patient. Of course, they usually go through a vigorous process of training before taking up for transplant, because it's long duration. As I told you, in the transplant process, they will be inside a room without any contact to the external world for 4 to 6 weeks, especially in haploidentical transplant. 6 weeks they will not come out of the room. Whatever said and done, they will not come out of the room. So it's a long, they will be in isolation. Of course, they have to take care of a lot of medications which has to be given orally, injections through the tube, infection control medications has to be followed. So it's like a factory. They have to, this time you have to give, at 8 o'clock they have to give that medicine, it has to go at 8 o'clock. It's like that. So infection control measures are there. Of course, giving physical support, emotional support, all those things will be there. So all these family members, they need to go through a vigorous training process before taking for transplant. So usually, and also when we have to communicate about the updates. For example, a patient undergoing cancer chemotherapy, we will only say, okay, 3 cycles you continue chemotherapy, and at the end of 3 cycles, we do a PET scan and we'll tell you whether it's responding or not. But in transplant, it doesn't work that way. There's nothing called tomorrow, because we never know. Today he may be alive, and tomorrow evening he may be sick with some organ damage or something. So everyday basis, daily basis, we have to communicate. So we can't be communicate with some part-time or a non-serious, irresponsible caregiver. So we want someone who is a very close family member to do it. So this is one important change. Yeah. The second thing is, of course, there are a lot of things which is discussed in transplant. As I told you, there is something called neutropenic diet, which many transplant process will advocate. Of course, we need to give us food which is safer. There is something called food safety guidelines by FDA. You just go through it once, FSG. So, of course, it depends on how you buy the food, how you cook the food, how you store the food, and how you give it to the patient. So all those things. FSG is a very important topic. I think everybody should go through it once. And I think it's very important to communicate to every patient. FSG, food safety guidelines. Third one, we have to, of course, they have to closely observe the symptoms, report if there is any issues. The patient will be having central line like chemoport or a Hickman line. So they have to take care of cleaning this. All those things will be there. Of course, nutritional support and bringing them transportation from the hospital. They can't come in a bus or a train or a metro. No. Transplant patients, they usually require isolation. So they usually prefer to either they have a own vehicle or they stay very close to the family so that they can close to the hospital so that they can directly come to the hospital if any complaints are there. Of course, the rigorous counseling, which I told you, of course, it will be at multiple levels. First, what do is we give printouts to them. They will go through it once, and later we share them the videos of how to take care of them in the wards. So yeah, first time it will be online counseling. So it will be then one-to-one question and answer sessions between the family members. Of course, there will be one more level of counseling which happens from the BMT nurse with the family caregiver so that they know what they can do. Because even the clothes and everything will be supplied inside the unit, so they can't carry anything. So and they can't come out of it. Okay, 2 days I will be there. Third day, one more person. No, it will not be allowed. So their food, everything related to them will be taken care in the BMT unit next. Yeah, of course, we give a lot of study materials for them to go through it once, what they expect as a caregiver, how they should maintain themselves also. So, of course, there are various burnout features because the caregiver himself will be there in the unit for longer duration. Of course, there are various symptoms they may develop. For example, they're not getting sleep. They will be quick, sometimes emotional lability, quick to get angry. Sometimes they're anxious or depressed. Sometimes they will feel helpless. Sometimes they're uninterested in anything, not eating anything, because they will be not seeing sunlight for a really long time. So sometimes they easily get flustered. Sometimes even in the rounds they will be depressed. So all these things, these are the common signs of caregiver burnout. So we have to identify the caregiver mode. It's very, very important thing, especially in transplant unit, because if you don't identify it, it will be reflected on the outcomes of the patient. Especially in transplant, it's very, very important. So what we do is that if they have any complaints, we usually address it immediately. Or what I do is we use something called self-care quiz. So we usually ask in the rounds, transplant rounds usually happen for half an hour to 40 minutes, where 1 or 2 minutes we dedicate to the caregiver also. What we do is we ask these 5 questions, out of which 3 questions are about their routine. Did they eat food? Did they sleep in time? How are they feeling? So these 3 questions, apart from it, we ask extra 2 questions. One is whether they are exercising regularly or they are going for a walk, whether they are feeling okay. The last one is, did they speak to anyone? Of course, with the current era where they have video calls and other things available, now they feel more connected to the family members. But previously, especially 10 years back when there were no mobile phones, it was really, really difficult, and we had to really struggle to communicate with the external world. Sometimes the attendants outside, they were really feeling that we are the child is not well inside and we are not telling them. So such barrier was there for communication. But of course, after this video conferencing, it's very much easy for now. So now we have a teleconsultation room where we have cameras installed, and usually we can ask the relatives to see what we are discussing with the patients also, as well as the caregivers. So these are 5 self-care quiz we usually ask. So these are things which will help us to identify at an earlier phase whether they are going for caregiver stress or caregiver burnout. Very much important. Every day we have to do it. Take 1 minute or 2 minutes, but very important. Of course, there are various ways you can prevent it. What we normally do is we follow some things like we have asked them to go for a walk. Along with the patient, they can go for a walk inside the room itself. Usually our rooms are a bit spacious. Of course, we have to tell them that they have to take care of their routine. So we usually supply their beverage of choice, for example, coffee or tea, whatever they want, food, whatever their choice. We usually give them an option. And of course, they can take help of our counselors or doctors whenever they are needed. And also we'll encourage them whenever the patient is sleeping, they can also rest so that they are well rested. So of course, apart from it, we do other things. For example, giving them some recreation. We have a television in each BMT room so they can watch whatever they feel like. We usually give them access to Netflix or Amazon Prime so that whatever language they are comfortable with, some things they can watch. We usually give them newspapers every day so they are in touch with the external world. Some novels, all those things. We have a book bank there which are kept and clean and kept. So that also we will provide. So these are the things which we are doing it to prevent caregiver burnout. And of course, if they have a burnout, of course, we need to talk to them. There is a separate team of counselors led by Dr. Pavitra and team. They will take care of things. Yeah, I'll just go through the last case scenario. So we have a baby S, 8-year-old with high-risk leukemia. After standard chemotherapy, child had responded well and the child is come for transplant because of a high-risk situation. Underwent transplant, received chemotherapy, radiation, underwent transplant. Child had delayed engraftment. Because of the delayed engraftment means the count recovery delayed because of the mismatched transplant or haploidentical transplant. Of course, child had some infections. For that, it was treated. So the stay in the hospital prolonged. And later developed GVHD, as I told you. Again, it's a vicious cycle of infection and GVHD. The child kept on staying in the hospital for almost beyond 6 to 8 weeks. So one fine day, the child didn't have breakfast in the child. Child is refusing. I don't want any breakfast. It's a small girl. And mother is shouting at the child. So mother is concerned about various things, of course. And later, emotional outbursts happened. Both mother is crying and later child is crying. So this is a situation which happened recently in our transplant wards. So I would like to get answers from the audience for this. What are the possible reasons for caregiver stress and burnout in this patient? Transplant, child, mother. It's a related caregiver. So it's isolation related issues. Yes.
Maybe mother wants to just normalize the situation.
Yes. No, probably the mother may be thinking that if she eats well, she may recover faster. Yes. Correct. So then the recovery may get prolonged. Correct. 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 So most important thing is she is stressed. The mother, there is already, so probably she is already burnt out because she, along with the child, she is there. Child may not worry much about other things. For example, finances. She may be stressed about that also. Yeah, of course, because of the long stay, the child and mother both can be stressed. The child is unwell, and probably if she doesn't eat well, again, the delayed recovery, that could be one of the reasons. Finances. So the longer the stay, so the mother may push in to make her eat faster so that recovery is fast. And of course, lack of self-care for the mother. So this is one thing which, although in spite of doing all this, taking so much efforts, still it can happen. And of course, it's a very difficult, so we involved our counselor team to handle such patients. So how to address, of course. Yeah, I would end my, of course, how to address you have to, again, we know, unless I'm not going to details of it. So I would leave at this slide. There are only 4 kind of people in the world. Those who have been caregivers, those who are currently caregivers, and those will be caregivers, and those who will need caregivers. So this is by Rosalind Carter.